It's my pleasure to introduce Sally Heppenstall, who's talking about paying attention to mental health and wellbeing and the interRAI contact assessment. Sally is a health social work and counselling, has a health social work and counselling clinical background. She's been around interRAI, I think she's been deeply embedded in interRAI for 20 years as a NASC assessor, an educator, a systems clinician, and working in home and community care, long-term care and planning and funding settings. She did a Master's in Health Science for Otago in 2016, and her thesis was funding community care for older adults on the interRAI RUG3 system. So welcome, Sally.
Okay, well, I'm here today flying the flag for home care providers. I work for Access Community Health, and in the audience today is my colleague Jen Larriman. We both teach as external accredited educators, ACC interRAI. We're the only two that do that as far as I know. And I suppose with my counselling background, I was interested in this topic of mental health and wellbeing. And ACC hasn't got much of a look in this knowledge exchange either, so it's covering those things. So I thought you might need a joke at this time of year. This time of day. This is my pepeha. I grew up on a dairy and pedigree pig farm in Otorohonga. There's me knee-deep with the pigs. I now live in Paikakariki, which is just north of Wellington, overlooking Kapiti Island. And I probably should have handed in all the cards when I left. I'm not impersonating anyone, but as I personally wrote that, it's a bit dicky really, but what Bridget read out, I've been around. And as a non-nurse, I've even been employed by Somerset. Employed by one of my mates who wanted me to embed interRAI into Somerset. Instead, I went before the auditors came and did 50 assessments, even though I'm not a nurse. Brilliant. I shouldn't have mentioned the employer, just forget that. They then made me redundant because I wasn't a nurse. So today I'm interested in the contact assessment because, as most of you will know, under a bulk funded model, the home and community support providers do the contact assessment for Te Whatu Ora. They're doing a version 10 from last August. ACC is on 9.3, but going to be doing version 10 in a month or two. So I've selected the mood items from both those assessments, and version 10 has a self-rated mood scale. I've got some data from both ACC and Te Whatu Ora, and this is only an ideas exchange. It's a 5-minute presentation and then discussion. I did my master's when I was 60. I am not starting a PhD at 70, which was in September. So if any of you have got colleagues who are doing study and are looking for a research topic, I think this one's quite a good one. So I've got a research proposition, but it's just there for anyone who wants it. And then I'm interested in your ideas. So as most of you will know, in version 9.3, it's very simple. In the last 3 days, have you felt sad, depressed, or hopeless? And I find with ACC, a lot of people respond yes, because they absolutely hate being dependent. So I'm not quite sure if that's the meaning of the item or not, but it picks up a lot of people. The mood items in version 10 are a bit more nuanced, and it's added to in the last 3 days, anhedonia, anxiety, sad, depressed, hopeless, angry with self or others. And then as it says down the bottom, higher levels of score, 3 or more, out of a score of 0 to 9, mean poorer self-rated mood. There are, in terms of well-being, there's a couple of other questions in version 10 about the degree of loneliness and also about finances and trade-offs, which brings in the sort of socioeconomic part of it all as well. And as you will know, in version 10, there's a mood scale, and this is what really interests me. read if you will. So the scales rated 0 to 9, scores of 6 or more suggest a need for a referral to a mental health professional. So I was interested to see how many people might be in that category. And that would be the basis of a research thing, you know, are there the resources, are people being referred by their assessors, etc. So just flicking back from version 10 to 9.3, this is the data that I got from ACC from Rebecca Blackmore. And it's raw data because my Excel skills just defeated me a couple of weeks ago. I haven't used them for years. So the data's by client age group, their sex, their ethnicity, and their case mix group. And the ACC case mix is 1 to 4. It's very different from the Te Whataora Matthew Parsons case mix. And the other data that Rebecca was able to give me was matching it with the stuff that assessors put into the ACC client portal about the outcome. People under the return to independence contract can get care for up to 6 months. And the case mix 4, they'd be getting shopping, meal prep and personal cares. Case mix 2 will be just personal cares. And as you know, ACC, or this is something for Te Whataora to consider, you don't have to do a contact assessment to get household management. So I'm also interested in the outcomes. Some got a partial independence, some were transferred to another service, some were transferred to fee-for-service. So having that match of data, I think is quite useful. And then the Te Whataora data, or that last data was just access data from 2023. The self-mood score, this is just an example from people who had a score of 9, which means quite a significant self-assessed low mood. And then again, it's by age group, ethnicity, and the assessment urgency algorithm. You know, if they're a 5 or a 6, they should be referred to the NASC or Canterbury Older Persons for an interRAI home care. If they're a 4, it's debatable. And then the case mix. So what interests me with this is that, I haven't got a pointer, sorry, but not using it. The 1Bs, I understand that they will, there's lots of variation, but when we get a national contract, they probably won't be able to have funded household management. But is anyone then taking care, paying attention to the self-reported mood scale of 9? And it's easy to see, you know, all this discussion 20 years on, sometimes interRAI is still called a needs assessment. We have to change that language to a comprehensive, well, this is a screening tool, but to a comprehensive clinical assessment tool. Sorry, we started early, but I can always spiel again later. Yeah, so that interests me. This is the, for those of you who have just come, this is the Te Whataora data for access for Cape Coast Q4 last year, and version 10 of the contact assessment, which is more nuanced in its mood questions. So I'm interested particularly in 1Bs who may not, will no longer be eligible for household management funded, but they may have a score of 9, which is quite a significant self-reported mood. And 6 or more, they should be referred to a mental health professional. Do we have appropriate mental health services? Do we have appropriate mental health services for Māori, Pacific, rural people? You know, and are assessors taking that into account? Because even we can see some of those people are complex, so they will get an HC. But the people who aren't, are the assessors still referring them to mental health support? So Jamie, later I'd be interested in your view about that. So as I said, this is only a research proposition. Sally Keeling, my lovely supervisor for my master's, I was saying, Sally, I won't be starting a PhD at 70. So this is just a research idea that can be passed on for free. So it's either, the other things that interest me are that it's a quality improvement project. You know, what is the quality of the care planning that assessors are doing, both at ACC and rehabilitative model for ACC and a restorative care model for Te Whatuora. Goal setting is also something that I teach and am interested in. If people have got low mood, you know, where are they up to with goal setting, and what do we have to do first? And then, as I said with the data, the case if it's 1A or 1B. Possible research questions, and very much having an equity lens with Māori and Pacific people, rural people, and with that socioeconomic item in version 10 about trade-offs. What is the outcome of referral to mental health professionals for tangata with self-rate and mood 6 or more, and what I was saying about goal setting. So I want to acknowledge these people, Rebecca and Robbie, who have provided the raw data, very easy to access, which was great. You for listening, and the people who wrote did the assessments, including Jamie, who's the team leader for Access in Wellington. So, what are
Thank you, Sally. Can I just ask a question? If the team, Jamie's back there with the team, so if the assessment team complete the assessment and it is a 1A or 1B, does the agency refer on to a mental health providers?
if there are 6 or 9?
If they are 6 or 9, so they do that? Yep.
I'd say there's work to be done in that space.
Okay.
Yeah, and limited understanding of interpreting the outcome scores. Yeah, so we've got a session actually in a couple of weeks with Sally, which we're much looking forward to.
I'll see you Monday week or Thursday week or something.
I was just going to ask. Oh no, I'm going to pass it to Ondine actually, because what I was going to ask was does the contract say anything about, because as you said before, we should stop calling it a needs assessment. When I was in the NASC, well, I still am technically, but you know, my comment was always, we're not the funded needs assessment service. You know, we need to be thinking beyond and thinking more holistically about what the individual's needs are, rather than just what contracts we have available to us.
Thanks, Simone. Look, I think this is a really interesting presentation because it's just brought to light that some really important changes to the contact assessment that happened last year that I don't believe are actually built into our current algorithms. And considering the refocus of the National Home and Community Support service model on a more clinical response, more clinically driven response, and a response for non-complex clients that is drawn to social isolation and loneliness in particular for this one, which I would associate with low mood, right? So I think we probably need to do a little loop back and just double check that for clients who are being seen by a home care provider who are having a contact where there is a score over 6, we probably need to loop that back in and have a wee bit of a think about how we manage that, because that isn't surfaced. It doesn't pop. The new mental health scores don't pop them into our awareness. It would be very easy with the current settings to just kind of, you know, they don't quite hit a threshold, so we're not going to worry about them right now. We're just going to say not eligible for this type of service. But in actual fact, our refocus is very much on the social mental health aspect of aging. So really, thank you, Sally. That's been, whilst I'm not going to do a PhD, certainly be thinking about that when I'm looking and talking to people about how we're refocusing our current national service specification, because that just falls in with the model we have in our national framework, which is that restorative, responsive, clinically driven rehabilitation, and just client-centered, right? Because I mean, I could talk to why this is so important. I think we all know why it's so important, actually, in the room. So thank you. Yes, quite excited about that.
Actually, can I just ask, does that new mood, does that build into the service? You know, the assessments, the algorithms, that because it doesn't at all.
Yes.
Right, okay. That's it, yes, and service urgency. Okay.
Jean, did you want to say something?
My understanding is they haven't revisited the algorithms since we've gone to version 10. That was put out there that they needed to be revisited because there are things in version 10 which are not in version 9.
So even if it's just a response that's required, if it comes up as a score, and that can be driven outside of the algorithm, actually. That could just be please take note, if this happens, then we expect this to happen.
Just online, Steve has come up with just a comment to say that mood is considered as part of the service allocation tool for them, which doesn't address a referral to the MH services. However, it does mean that clients will have a more in-depth assessment, e.g. a home care. Sally, just an extra comment. Sorry, Karen. Sally Hollinshead. Thank you, Sally. Very interesting to see the data, read the ethnicity and representation in the figures. Thank you.
Sally's a colleague of mine, so thanks, Sally. We've got a PhD in you. It's not PhD material, actually, but something. Research project.
So can I just, I'm trying to catch up what this conversation had. So Ondine is saying she thinks it wasn't in the algorithm, and we've got a person online who's saying it is in the algorithm?
It's in the case mix, but not the algorithm.
Thanks, Mike.
And we're just double checking that now.
Yeah, so we'll loop back and double. check.
Right, I think that's
Yeah.
good. Yeah. I mean, I just want to make a comment. This goes right back to introducing interRAI, where we said understanding the person's, preferences and strengths, etc., is only one part of the picture. It's what you're going to do about it.
Yeah.
And interRAI is about, having a validated way of identifying need. No, I'm not talking about needs in the home and community support sense here. I mean identifying need. And then the service response has to match that need. And I think it is easier in age residential care when you can look and see, here are the needs. Here's the care plan that was developed against those needs. But because home and community support have a variety of providers, it is technically harder, isn't it? Yeah. But there is no point in having this wonderful new information and then do nothing about it. So that's a great challenge. So I'm glad you're in the room. Glad you're in the room to have that pointed out. Any other thoughts about this or any other matters? Because one of the things is that interRAI does bring out, I mean, it's a living organisation, so it does bring out new scales all the time. And we have to be alert to that. So
Yes, Natasha online has asked, what can we do to support psychogeriatricians we currently have and grow the next generation of mental health clinicians working with older adults, including mental health nurses supporting older adults?
Oh, I've got a response to that.
Yeah.
When I worked for FIDU, which was the 3 GHBs in the Wellington area with Ondine, my job, I was a systems clinician, but my job there was to support geriatricians, etc., to learn about interRAI. And I think, one of the losses has been that with all the practitioners and educators and system clinicians coming into here is I know you have local relationships, but probably, I don't know if you're so able to go out and round about. So I used to spend quite a lot of time educating psychogeriatricians and about interRAI, whether they took much notice or not, I don't know. But there was one innovative GP person, like Mary Curse, who got me to come and teach med students about interRAI. It just happened to be about Easter, and they were mostly on their phones planning somebody's engagement party or passing the card around. And I just thought, how rude, but apparently these bright young things can multitask as well as taking them. But I wasn't invited for the next year, so I don't think it was a hit. But, there are things, and, when Bridget and I talked about this being the 20th anniversary, this is going off track, of course. But I think I'm interested to hear what John Hurdes has been saying on the radio and who might have heard it. I think there is an article, if any of you read The Listener, that you can write 600 words. I've just got as far as doing a brief sketch of what I'd like to tell the world about interRAI, but that might be something other people might be interested in doing, because people don't know. They don't know how, I'm often a navigator of the aged care system for people. In my world, I guess we all do that. It's hard to navigate, and I've gone off track of that question, sorry, but I think there are ways that we can, it's all about building relationships, and I know interRAI New Zealand build relationships all over the show, so it's taking those things up. And I don't know if you go to the geriatricians conferences and stuff and fly the flag, you probably do. You got any other ideas of what? We shove it in their face. There's got to be a benefit, and I guess that Auckland University stuff might feed it to them in a language that they can understand. But I hate the thought of interRAI language being reinterpreted, because that was the thing. We all learned a language and we can talk to each other, and surely bright people can learn a little bit more. Anyway, I will stop.
Well, that's a great place to finish. So thank you very much, Sally.